Thank you for the invitation and the opportunity to speak about BTK inhibitors. As you mentioned, we have done a number of works on that, starting from the biology, because that's the relevant point. We understood in past 2 decades that the B-cell receptor and many other receptors on the surface of CLL cells are signaling inside the cells through also BTK, and the inhibition of BTK has been shown, has proven to be very effective. And in fact, we have now 3 generations of the molecules just to show and underscore how relevant is the inhibition of this pathway. So first generation is Bruton, the first one for which we have now more than 10 years of follow-up. And then we have the second generation of calabrutinib, zanubrutinib, that tend to be more specific with less adverse events. And third generation, pirtobrutinib, netabrutinib, that are still in phase 3, have shown already activity in the relapsed refractory setting. We will see the results in frontline. And the idea that what the inhibitors of BTK also showed and proved is a new concept in the treatment of patients. So the continuous treatment, that seems really strange and awkward when we start working on that more than 10 years ago, but that's become now a standard, and proven that the continuous treatment with BTK inhibitors is able to is superior in any setting compared to chemoimmunotherapy in any setting. So against FCR, like in the ACOG 1912 study, against BR, bendamustine plus rituximab, like in the Lion study, or against chlorambucil or chlorambucil plus obinutuzumab, like in the Resonate 2, they illuminate, they elevate TN, and in the Sequoia study, zanubrutinib against bendamustine plus rituximab. In the relapsed refractory setting, again, all the BTK inhibitors have shown, in this case, ibrutinib and calabrutinib, to be better than the standard therapy at that time. And of course, now when we look at the comparator, they seem very inefficient. But that was the type of therapy that we had 10, 15 years ago. Now, how can we improve? Because continuous treatment is proven to be effective. Long-term disease control, even in high-risk patients, P53 patients tend to have a very similar PFS compared to all other patients. Definitely patients with unmutated immunoglobulin genes respond for as long as patients with mutated immunoglobulin genes. It's an oral therapy, which is very convenient for both patients and physicians. And but it's continuous therapy. So continuous therapy means continuous cost, continuous exposure to drug, so possibility of adverse events, and the possibility in particular of clonal evolution and resistance. So when patients relapse under a BTK inhibitor, then the disease is really resistant to that class of drugs. That's why the idea of time-limited treatment came forward, and now it's becoming very popular, and that's where most of the research went in the past few years, and is going also in the future. And the combination, as you know, include venetoclax. They have as a backbone venetoclax, because in order to have a fixed duration treatment, you need to achieve deep responses, where that only venetoclax can achieve. And then venetoclax can be combined to either anti-CD20 antibodies, we know obinutuzumab in frontline, and but also with the BTK inhibitors. And that's what happened. And in fact, we designed a few years ago, together with Konstantin Tam and Bill Virda, the Captivate trial, which is a phase 2 trial, international trial, where ibrutinib plus venetoclax was explored, the combination of the 2 drugs for 15 months, 3 months of ibrutinib to debulk the patient, and then venetoclax in combination with ibrutinib for 12 months. And then we had 2 different cohorts. They were not randomized to each other, but they were 2 different cohorts. One where patients were stopping treatment only if achieving undetectable MRD, and they were compared instead to continuous treatment, even in the presence of undetectable MRD. But then also the fixed duration cohort, that is the one that led to the approval of the fixed duration approach. So 15 months, 3 of ibrutinib, 12 of the combination. and everybody stopped regardless the response and the level of undetected MRD. The results have proven to be good, particularly very good, I would say, regardless of genomic features. We were able to achieve undetected MRD in every category of patient, including patients with P53 aberration, though they achieved undetected MRD in a lower fraction or frequency compared to the other patient. And that translated into the PFS that you can see here. When you look at all patients after 5 years, 2/3 of the patients are still responding, not progressing. When you look at patients with deletion 17p or p53 mutation, if not complex karyotype, it's only 50%, roughly 50% of them still a relevant response. I mean, it's only 15 months of treatment, and then for almost 4 years of therapy, and still 50% of the patients are not progressing. So we have to think also about the use of fixed duration, probably in this high risk category. Of course, when you look at patients without deletion 17p or p53 mutation, 3/4, 77% are still responding after 5 years. So definitely for those patients without deletion 17p and p53 mutation, the fixed duration treatment appears to be a very promising, very effective treatment. When you look at the PFS based on immunoglobulin gene status, which is probably what we are all interested, at least in Europe, as you have seen from the ESMO guidelines, if you look at the patient when you exclude the deletion 17p and p53 mutations, then it seems to be very effective for both mutated and unmutated patients. 85% of mutated patients, that's the highest frequency, the highest rate of PFS that we can obtain in the study. That's expected. Patients with mutated immunoglobulin genes do respond to virtually everything, including immunochemotherapy. So there we have to make decisions based on the safety, not to harm the patient. But 68% in patients with unmutated immunoglobulin genes and without p53 or deletion 17p is a very good number after 5 years. So again, only 1 year of treatment and 4 years of therapy. And that's the reason why in the ESMO guidelines for the young, in particular the young fit patient with unmutated immunoglobulin gene, that's become one of the suggested options, if not the first suggested option. In the next slide, which is not advancing anymore, and in the next slide we are looking at the GLOW study, which is the same combination, ibrutinib plus venetoclax, but in the elderly population. Captivate was designed for fit young patients. The GLOW was designed for elderly patients. Was a phase 3 study that really helped for the approval, and was the ibrutinib plus venetoclax combination, same 15 months, was compared to chlorambucil plus obinutuzumab, and it turned out to be, of course, superior, and superior in terms of responses, superior in terms of PFS, superior in terms of overall survival. But what I think is most interesting for doctors, physicians, and patients is the time to next treatment. In particular in the elderly, where we want really to limit the treatment as much as we can. And so this patient, after 54 months, so roughly 4.5 years, they 87.9, so 88, almost 90% of the patients did not require a second-line treatment after 4.5 years. So that's what, again, it might make ibrutinib plus venetoclax the only treatment that a great portion of patients, elderly patients, will indeed use or be treated with. Those results were obtained without major increases in terms of safety. In particular, there has been only an increase in diarrhea that is typical of both the drugs, venetoclax and ibrutinib. When they are combined, 50% roughly of patients will experience diarrhea, which is typically grade 1 and 2, and disappear within a few weeks. But in terms of major adverse events, we didn't see any particular increase. If you look on the right side, the Captivate trial, we observed the neutropenia, grade 3 or more neutropenia, in exactly the same frequency that you would see with venetoclax monotherapy. Grade 3-4 infection, still were very low. So 1/3 had grade 3/4 neutropenia, only less than 10% had grade 3/4 infection. So really indicated that it did not increase the number of infection. If you look at the left side, in the elderly population, because they are elderly, we have always to remember that they have already comorbidities. So we do see more cardiac events, and also we do see more infections compared to the young, but that's typical of the elderly. So we have always to keep an eye on them and be more careful. So the triplet combination, so ibrutinib plus venetoclax, and on top of that, the obinutuzumab anti-CD20 antibody has been studied in the Gaia CLL 13 study, an international study led by the German CLL study group. And here they compared all different venetoclax combinations: venetoclax plus rituximab, venetoclax plus obinutuzumab, venetoclax plus ibrutinib and obinutuzumab, and they were compared to either FCR or BR, so including young and fit young and elderly, let's say. And what it turns out that the triple combination is the winner compared at least to immunochemotherapy, because at the moment there is still, it's not clear, though the long-term data seems to prove that the triple combination can be even superior to the venetoclax plus obinutuzumab treatment. In the triplet arm, there were more infections. Because probably of the introduction of obinutuzumab. So again, we have to keep in mind that probably the triple combination is not a treatment for everyone. We have really to select probably again a young and fit patient. In the next slide, yes, we just going through more triple combination like acalabrutinib, so second generation BTK inhibitor plus venetoclax plus obinutuzumab, and this was a study by Matt Davids, and again shows we don't even look anymore at overall response rate. We do achieve now easily, let's say, 100% responses. We have now to change our attitude when looking at the data. We have to look for undetected MRD, which is probably more representative of the efficacy of these new combinations. And as you can see here, it looks very promising, again, with numbers that are all above 80%, even in patients with a BRAF P53. And up to 90%. Of course, this was a phase 2 study, so we have to see it in randomized fashion in phase 3 study. And that is what is going to happen at ASH. Jennifer Brown will be presenting the data, if accepted, for oral presentation. I think it has been accepted for oral presentation. And we are going to publish the results on the amplified trial, so a trial comparing acalabrutinib plus venetoclax and acalabrutinib plus venetoclax plus obinutuzumab to they were compared to FCR and BR again. And at the moment we cannot disclose the results, but publicly there's been a press release indicating that there has been a clinically meaningful improvement in PFS for acala plus ven plus or minus obinutuzumab compared to chemoimmunotherapy. Overall survival is too short to say, but the trend is positive again for the acala combination. So this is the current knowledge. How can we improve further with MRD? As I mentioned, probably the possibility would be to use MRD to drive the treatment, and that is what is happening in the different trials. One is the Bovin, where zanubrutinib, again another second generation BTK inhibitor, was associated to venetoclax and obinutuzumab, and here the design of the study allowed to stop the treatment if patient achieved undetected MRD. Again, this is a question that Professor Sal presented earlier. 89% of the patient achieved undetected MRD in both peripheral blood and bone marrow and discontinued therapy. So 89%, again, numbers that are really very, very high. We're not even talking about overall response. This is undetectable MRD. We will see also there in phase 3 study how it goes. The FLAIR trial presented last year, published in the New England Journal of Medicine, is led by the British, by Pete Hillman and Tal Munir, compared ibrutinib plus venetoclax versus FCR. This is a very complicated study. The length of the duration of treatment with ibrutinib plus venetoclax was based on the time that each patient needed to achieve undetected MRD, and it was doubled. So if it took 1 year, you would do an extra year of treatment. If it took 2 years, you would do an extra 2 years. If it took 3 years, you would do an extra 3 years for a maximum of 6 years of treatment. And those are the results with this strategy. 97% of the patients are still relapse-free after 3 years of follow-up. Overall survival, we don't even look at that. But it's significant compared to SCR. So MRD will be the future. It can be used to predict who will have a longer PFS or overall survival. It can be also used in a short term to understand which combination is better compared to others. It can maybe in the future in the clinical setting, not now definitely, where there are no proof and no data, we could guide the treatment in the clinical setting based on MRD. We could even think of treating patients based on relapse of MRD without really waiting for the clinical relapse. Future perspective is a number of studies that will try to solve some questions like better continuous treatment or fixed duration treatment. The CLL 17 trial, again, international study from the German CLL study group, comparing ibrutinib continuous treatment versus venetoclax plus obinutuzumab and ibrutinib plus venetoclax as fixed duration. The next trial will be the CLL 16, where venetoclax plus obinutuzumab plus acalabrutinib will be compared to venetoclax plus obinutuzumab as a standard treatment. These are all both fixed duration. More interesting, I think, for the future is the study led by Matt Davids again, the MAGIC trial, where acalabrutinib plus venetoclax is compared to venetoclax plus obinutuzumab again, but it is MRD treatment. So patients can stop based on MRD, or they continue and intensify the treatment based on MRD. But MRD can also be used to de-intensify, so decrease the quantity of treatment. That's the trial led by the ERIC, the European Research Initiative on CLL, the RESOLVE trial. Patients will be treated with standard of care BTKI plus venetoclax or venetoclax plus obinutuzumab, and those who achieve undetected MRD at 6 months of treatment, they will be randomized to either stop or continue to the standard 12 cycles. And we will see if we can save adverse events, keeping the same PFS to our patients. With that, I conclude, and as we mentioned, with novel oral targeted therapy, we have significantly improved the outcome of our patient in frontline. Doublet and triplet combination have shown very encouraging outcomes. The doublet are already approved, or soon that we will have more approval. And MRD guided can probably be in the future a key way of treating our patients.